welcome to all our chairs, speakers, and wonderful audiences of the ACNS webinars around the world. Welcome back to yet another edition of very insightful lectures for you. The speaker for the first session of today is our renowned faculty from Seoul, South Korea, Professor Do-Sik Kong. Professor Kong is a professor of neurosurgery at the Samsung Medical Center, Singkyung-kwan University, Seoul. His clinical practice is focused in the management of brain tumors through minimally invasive surgery and also gamma knife radiosurgery. Professor Kong is an invited faculty for various workshops and congresses conducted all around the world, and he's also a noted author with several publications in various peer-reviewed journals. We are extremely thankful to him for accepting our invitation as a speaker at our webinars, and today he'll be talking about Orbit, a new path to skull base, no longer a goal. The second speaker for today is our honored guest from Malaysia, Dr. Muhammad Azman Rafiq. Dr. Rafiq is a consultant neurosurgeon and head of Department of Neurosurgery at the Jabatan Neurosurgery Hospital, Pulau Pinang, Malaysia. He is also an important member of the Neurosurgery Association of Malaysia and the AO Spine Malaysia. He reserves his surgical practice in cerebrovascular and skull-based surgery and spine surgery. He is also a noted author with several publications in various peer-reviewed journals. We are extremely thankful to him for accepting our invitation to speak at our webinars, and today we'll be talking about AVM, surgical planning techniques, complications, and lessons learned. The chair for the first session of today is our honored guest from Japan, Professor Taki Goto. Professor Goto is a professor and chairman in the Department of Neurosurgery at the Osaka City University Graduate School of Medicine, Osaka, Japan. Professor Goto is a very important member of the Japanese Neurosurgical Society, and he has been an active member of the ACNS and also was an integral part of the ACNS delegation to various conferences and workshops organized worldwide. He has published several articles in various peer-reviewed journals, and is currently serving as a co-chairman of the Skull-Based Committee of the WFNS. We are extremely thankful and honored to have him today to chair the session of Professor Do-Sik Kong. The chair for the second session of today is another world-renowned faculty from China, Professor Xu Bin. Professor Bin is a consultant neurosurgeon at the Huashan Hospital, Fudan University, Shanghai. He is an important member of various neurosurgical societies in China, as well as the vice president of the ACNS. His clinical practice is focused on cerebrovascular surgery, and he has the largest number of bypass from OMR in this world. He has been instrumental in propagating the educational activities of the ACNS in his country, and we are extremely thankful to him for accepting our invitation to chair the second session of Dr. Muhammad Azman Rafiq. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely welcome all the speakers, chairs, and the audiences to this online platform of ACNS webinars. A warm welcome to all our viewers in China, and we are extremely thankful to Professor Xu Bin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this virtual podium to our first chair, Professor Taki Goto.
Good evening. Today I feel very honored to chair the session of this meeting. I think a few years ago, I listened to a lecture of Professor Do-Sik Kong for the first time about the endoscopic transorbital approach. I think it was very, very interesting and exciting lecture for us as skull-based surgeon. Today, I think that Professor Do-Sik Kong will give us a good or fantastic lecture about the endoscopic minimum invasive skull-based approach. I think that now Professor Kong is leading the expert in this field, so I am very excited to listen his lecture. So Professor Kong, please give us a lecture about the endoscopic transorbital approach. Maybe please start, Professor Kong.
Thank you, Professor Goto, for nice introductions, and thank you for inviting me, Dr. Raja. And then today I'm going to talk about the endoscopy transorbital approaches. The title of this topic is Orbit, a new path to the skull base, no longer goal. I'm Do-Sik Kong from Seoul, Korea, Samsung Medical Center. And I'm going to talk about the endoscopy transorbital approaches. Everybody knows the endonasal approaches is not targeting the nasal cavity, but the goal of the endonasal surgery is to reach the intracranial or skull-based regions. And similarly, endoscopic transorbital approach's goal is to reach the skull base, not to reach the orbit. This is sphenoid bone. Early endoscopy endonasal surgeons described the extent of endonasal approaches. For example, sinonasal tract, lateral recess of sphenoid sinus or pterygopalatine fossa or infratemporal fossas can be accessed with endonasal approaches. And also frontal areas can be accessed with the supraorbital or mini craniotomy or mini pterional approaches. But cavernous sinus and middle cranial fossa has limitations with the endoscopic approaches. Then nowadays, I think transorbital approaches can provide the corridor to the middle cranial and cavernous sinus areas. This is the axial view of the skull base. The midline lesions can be accessed with the endonasal approaches. And also frontal areas can be accessed with the supraorbital approaches. And finally, the temporal side of the lesions can be accessed with the transorbital approaches. I think this area can be approached with the transorbital or retroorbital or endoorbital areas. I'll talk about the proof of concept of transorbital approaches. This tumor is located within the middle cranial fossa, and some portion of the tumor is extending to the posterior fossa. We call these tumors the trigeminal schwannoma. Traditional skull-based surgeons favor anterior pterygoid approach or FTOG approach from the tumor, the anterior part to the posterior area. And other surgeons favored posterior lateral approaches or posterior pterygoid or retrosigmoid approaches. Instead of these conventional transcranial approaches, endonasal endoscopic surgeons favor endonasal approaches from the midline to the lateral side. But the major limitation of endonasal approach is the very difficult to reach the most anterior and most posterior part because of the barrier of the internal carotid artery. So we need to avoid the crossover the ICA, and then I select transorbital approaches can avoid the ICA, and then we can easily access to the lateral part to the ICA area. I have experienced this trigeminal schwannoma maybe 7 or 8 years ago. I selected the endonasal approaches, and then after operations, then some tumor part was left, even regardless of my effort, long time effort with the endonasal approaches, because this part is ICA. ICA, some part was hidden behind the ICA area. So I thought that endonasal approach is still very challenging to reach the lateral part or middle cranial fossa areas. Then nowadays, I selected the transorbital approaches, and then we can easily access to the middle cranial and posterior cranial fossa tumors. Transorbital approaches provide more direct view and shorter distance than the endonasal approaches. And also, we can spare the median nerve. Transorbital approaches does not need to sacrifice the median nerve. With many advantages. Now I'll talk about the axis of the tumor. This is the olfactory groove meningioma, left side. And then everybody knows what is the optimal surgical approaches for these tumors. The axis of the tumor is the anterior to posterior directions. Then I think that the optimal surgical approach should be parallel to the axis of the tumors from anterior to posterior area. So in such case, I favor maybe transcranial. I know so I can do the endonasal approach is possible, but still we have to face the large defect of the dura. So instead of that, I favor follow the axis of the tumors here. For example, this is a vestibular schwannoma. Then the most common, most of the surgeons will select the retrosigmoid or translateral approaches. This is pterygoid meningioma. We have to know the long axis of the tumor is here. Then we can select the what is the optimal surgical approaches. How about craniopharyngioma? The direction of this tumor is here. Then I thought the endoscopic endonasal approach much more optimal approaches for these craniopharyngioma cases. Let's see these types of the tumor. The midline, midcranial fossa involving cystic trigeminal schwannoma or sphenoorbital tumor, and some tumors involved orbit and also extending to the cavernous sinus. And then let's talk about the long axis of tumors here. Then I thought that from anterolateral to the posterior medial side directions, then transorbital approaches provide a very similar direction of the long axis of the tumor. In terms of the cosmetic issues, transorbital approach do not open the cranial outer surface of the cranium, only open the intracranial portions, only open the lateral orbital wall, is composing of the greater sphenoidal wing. As a result, there is no depression of the outer bony surface. And this case is after operations, after large craniotomy, and also transorbital approach does not need the temporalis muscle retractions, only open the greater sphenoidal wing. It requires no brain retractions. In terms of the cosmetic issues, only transorbital approaches can leave the very minimal scar along the superior eyelid crease. I have experienced about 100 cases for recent 5 years. Most common pathologies were meningioma or schwannoma or other malignant tumors. I'll talk about the surgical approaches in detail. We have to know the anatomy of the external eyelid. We don't have to know the intraorbital structures such as cornea, lens, or vitreous tumor. We don't have to do it. We don't have to know about it, but we have to know the skin and muscles and composing the external eyelid. And then let's see, this is skin and orbicularis muscle. Then we just inside the skin and orbicularis muscle and dissect this area, target plate, orbital septum, fat, and the final goal is to reach the orbital rim. Orbital rim is bony surface. Then our incision direction of the dissection is here. Then after incision skin, then we dissect the orbicularis muscle. Then we need to preserve the orbital septum. It's very important to preserve the orbital septum. Only divide the orbicularis muscle, then we dissect the loose areolar tissues from the orbital septum. Then we can easily reach the lateral orbital rim here. This is a real operative field. This is orbital lateral, this is our final goal of the lateral orbital surface. Then we incise the periosteum. And then periosteum is connected to the periorbital, then elevate of the periosteum can communicate with the periorbital, then we easily elevate the periorbital from the lateral orbital wall here. Then after finishing the orbital phase, and we need to find the landmark of anatomy. It's a very good landmark of this anatomy is superior orbital fissure. After elevating the periorbital, and we need to identify the superior orbital fissure. Based on the superior orbital fissure, lateral orbital wall and superior orbital wall was divided. If you enter the superior orbital wall, you can face the frontal base. If you enter the lateral orbital wall, you can meet the anterior part of temporal lobe. Then, because as a result, superior orbital fissure is a very important structure. We drill from the lateral to medial wall into the temporal side. Then we can expose the fully anterior temporal lobe side and the meningo-orbital band and periorbital and cavernous sinus areas. Then we need to enter the cavernous sinus. We need to dissect the temporal dura from the outer surface of the cavernous sinus. This is a very common procedure in the field of skull base areas. And using the endoscope, we can easily we can dissect the dura propria from the lateral wall of the cavernous sinus. And then sometimes we need to obtain the working space for to reach the lateral part of the meningioma or the lateral portion of the temporal lobe. Then I recommend to remove the lateral orbital rim. Then after operations, we need to reposition the lateral orbital rim. How to reconstruct this this defect? I usually use the Dualogen to close the outlet to the posterior fossa, and then fascial lata or allodermal graft is a very good for the inlet to the cavernous sinus, and fat graft is very optional, only for the meningioma. And after operation of the meningioma, sometimes there is a very huge defect of the dura. In such cases, I recommend put the fat graft to occupy the dead space. And sometimes the lumbar drainage is good options, but nowadays I do not perform the lumbar drainage routinely. And sometimes we place the medial plate, but we need to prove the efficacy of medial plate to avoid the enophthalmos. I'm not sure. And for skin closures, we use the 5/60 nylon sutures. The major indication of transorbital approach is composing of 3 indications. First one is spino-orbital meningioma. Second one is trigeminal schwannoma. And third one is orbital apex lesions. I'll talk about the major indication of transorbital approaches now. And next 3 indications are the challenging indications, and petrous apex lesions, temporal parenchymal lesions, or infratemporal fossa lesions. And nowadays, I'm now trying to access the lateral compartment of the cavernous sinus, and then we can easily reach the posterior compartment of cavernous sinus behind the ICA to remove the pituitary gland, pituitary tumors, I'm sorry. First indication is spino-orbital meningioma cases. Spino-orbital meningioma mainly involve the anterior temporal tip and inducing the hypertrophy of the greater sphenoidal wing. So we need to remove the greater sphenoidal wing and the anterior part. And sometimes the tumor infiltrates the temporalis muscle or extraocular muscles. I think the spino-orbital meningioma is not benign clinical course. Benign tumors. It's very highly infiltrative to the surrounding tissues, and if possible, we need to remove the tumor's growth totally. And then if you leave the tumor, some tumors shows very aggressive patterns, has changed to the malignant or atypical patterns. So I think that the total removal is very important for this type of the tumor. This patient complained of the proptosis on the right side, and she complained of the compressive neuropathy. The tumor is already involved the frontal and temporal and even to the cavernous sinus here. The tumor is invading into the orbital space and involving the cavernous sinus, but there was no cavernous symptoms. So I thought that I need to remove the tumor as much as possible, but some tumors within the cavernous sinus may be left. And we perform the transorbital approaches. After inoculating, stop the local anesthesia. This is lidocaine mixed with epinephrine. Then we incise the superior eyelid crease. Eyelid incision is a very simple skin incisions. Then you can find the orbicularis muscles. This is a very important step because every neurosurgeon is not familiar with the external anatomy of the orbit area. This is a loose areolar tissues. Then by dissecting the orbicularis muscles from the orbital septum, we can easily reach the lateral orbital rim. Then this is the lateral orbital surface. This is bony surface. The soft tissue overlying the lateral orbital surface is very safe. You can safely use the monopolar coagulators. So I recommend my fellow and my resident you can freely use the monopolar coagulators overlying the lateral orbital rim. It's like the scalp and an incision. And then, I'm sorry. In these cases, we perform the lateral orbital rim osteotomy here. This is a lateral temporalis muscle. Then this is the superior orbital wall, the lateral orbital wall here. Already the tumor already involved in the orbit areas. We can easily found the tumors involved the orbital areas. This is temporalis muscle here. Then we identify the lateral margin of the tumor. Then we drill the greater sphenoidal wing. We have to know the shape of the greater sphenoidal wing is triangular shape, not the flat bone. So we need to drill the main body of the greater sphenoidal wing, and it will take some time. Sometimes it's 30 minutes or 40 minutes, depends on your experience. After total removal of the greater sphenoidal wing, we can easily identify the intracranial part of the main jaw. This is the foramen rotundum. Then maybe this is a foramen ovale area, base of the temporal lobe, and we can identify the temporal part and orbital. We can expose even the frontal side at the same time. This is one surgical field. We can expose the frontal, temporal, and orbital part. Then along the tumor margins, we can remove the tumor. This is the benign tumor. And then this was the hypertrophied anterior clinoid process. We drill the anterior clinoid process involved by the tumor. Here, this is the orbital part. We incise the periorbital. Then some part involved in the extraocular muscles. Maybe this is the lateral latissimus muscle. And then we identify the tumor mass from the lateral latissimus muscles. Fortunately, this tumor was safely separated from the extraocular muscles. But sometimes some tumors are very fused with the extraocular muscles after operation of the tumor, and you may sometimes found the extraocular muscle was disappeared. This is the optic canal, and then we need to decompress the optic canals from the tumor. Then some tumors are left within the cavernous sinus. This is foramen rotundum. Sylvian vein, you can expose it. And then we remove it. And then we reconstruct the defect of the tumor. After operations, and some tumors are left within the cavernous sinus, and you can find a large defect of the bony surface, but there is no the bony depressions. And then we reposition the lateral orbital rim here. And next indication is trigeminal schwannoma. I think the trigeminal schwannoma is a very, very best indication of transorbital approaches. I have experience of 24 cases of trigeminal schwannoma cases. The most tumors involved the middle cranial fossa tumors, and gross total or near total resection rate was about 80%. Trigeminal schwannoma has a very various type of the tumor. Some tumors involve the middle cranial or involve the orbit or infratemporal fossa. But I think that posterior cranial fossa tumor is not good indication of transorbital approaches. But except the posterior fossa involving tumors, and other tumors can be accessed with the transorbital approaches. And then only for the posterior cranial fossa tumors can be approached with the retrosigmoid or other posterior pterygoidal approaches. But the anterior dumbbell shape or extracranial type or midcranial fossa type can be accessed with the transorbital approaches. This patient complained of V1 hyperphagia, long time history of the 4 years ago, she had a history of the radiosurgery. The tumor involving the middle and some tumor part extending to the posterior fossa. We performed transorbital approaches. After incision of the skin, the length of the skin is reduced. Only we need to identify the lateral part is enough. Then we coagulate some recurrent meningeal or some branch. Maybe this is a superior fissure. Then in these cases, we don't have to remove the lateral orbital rim, only drill the greater sphenoid vein. But it's very important to drill the base of the temporal lobe. Then this is a maxillary strut or sestal crest. And then we identify the meningoorbital band. This is the interdural dissection from the temporal lobe and the outer surface of the cavernous sinus. This is we entered the cavernous sinus. The cavernous sinus was bulging from the tumor mass. This is B2 and intratumoral debulking with the sonopet. And then you can find some tumors were relieved. Here, this is oculomotor nerve. And then we remove the tumor. This is the outlet to the posterior fossa. This is the door to the posterior fossa. Maybe this was the disrupted V1 or V2, because I thought that the disrupted the trigeminal lobes was attributable to the radiosurgery. And after opening the posterior door to the posterior fossa, you can find the trigeminal fascicles and disrupted fascicle. This was the anterior surface of the brainstem, maybe some perforators. I closed the defect with the Duragen. Then using the fascia lata, I closed the anterior point of the cavernous sinus with the taco shears. We close it. And this is Medpore to avoid the post-op endophthalmos. And then we close the skin. After operations, there was no, I'm sorry. After operations, there was no cosmetic issues and all tumors were removed. This is another case of trigeminal Schwannoma cases. This was a very small sized tumors. It's very good indications of transorbital and minimal invasive surgery. And using the same surgical technique, we elevate the periorbital. This is a very common anatomical structures, recurrent meningeal arteries, and we can easily coagulate the monopolar. And this is zygomatic facial artery. Maybe this is the inferior orbital fissure. And then we remove it's very important to remove the maxillary strut composing the bone between the V1 and V2 space. Then, yeah, this is maxillary strut. This is the meningoorbital band. I'm sorry, my computer has something wrong. I'm not embarrassed. This is very common things for me. Yes, I skip it. And then I open the cavernous sinus. And after operations, whole tumors was gross totally removed. This is another case. The 67-year-old woman complained of the middle cranial fossa tumors, and she complained of the paresthesia on the left side after operations. Yeah, I performed the similar surgical procedure. And then here, I'm sorry. Yeah, this is pre-orbital fissure, lateral orbital wall. I think the trigeminal Schwannoma is very important to tumors to learn the transorbital approaches. And we need to identify the pre-orbital fissure, identify the lateral orbital wall, and then we have to know the shape and the thickness of the lateral orbital wall. Lateral orbital wall is composing of the triangular shape, and it takes very long times. Then we expect it. Then we keep up to the drilling of the bone here. And after, the next indication is the orbital apex lesions. Can you see these presentations?
Yes, we can.
Yeah, and orbital apex lesion is a very good indication of transorbital approaches. And my concept is the medial side of the tumor can be accessed with the endonasal approaches, or inferior part or superior part can be accessed with the endonasal approaches, but lateral part of the orbital tumors can be accessed with the transorbital approaches. The more important is how to identify the location of optic nerve. Here, this patient had a eyeball tumor, and then the tumor is here. We need to identify the location of optic nerve here, and then the tumor is located the inferolateral part of the optic nerve. So we selected transorbital approaches because compared to the endonasal approaches, then we remove the tumors totally. The approach is almost the same as trigeminal schwannoma or the meningioma cases. And after identify the lateral orbital rim, then we expose the periorbital and then identify the supraorbital fissure. You can find that. We drill the lateral greater sphenoidal wing. It's very important to remove the greater sphenoidal wing because we need to obtain the working space. And then we open the periorbital, then we can identify this easily the tumor outer surface. And then after debulking of the tumors, we remove the tumor's growth totally. You can find the distal part of the nerve. Maybe this tumor was schwannoma masses, but because unknown origins. And then here, then we finished to totally remove that one. And sometimes trigeminal schwannomas involved to the orbit areas, and after operations, the patient complained of the complete ptosis after operations, but in 1 year, she recovered fully, and then all tumors were removed. This is another case of the oculomotor schwannoma. Oculomotor nerve is divided into superior branch and inferior branch within the orbit areas, and then we remove the tumor with the transorbitally. Then, yeah, here, and pre-op patient face photo, and post-operatively, she recovered fully. And next, I will talk about transcaruncular medial transorbital approaches. And sometimes the medial size of the tumors within the orbit areas, we can open the transcaruncular approaches. Dr. Chris Moore described that one. Then this patient complained of the recurrent tumor on the right side. You know the tumor is located the medial side. I thought that endonasal approach must be a very good indications, but the patient lost his visual loss on the right side. This was the recurrent cases of the tumor. And instead of the endonasal approaches, I tried to the transcaruncular approaches to reach the medial size of the tumors. This is a caruncle area. Then after incision of the caruncles, we can identify the tumor mass medially located within the orbit area. This is the caruncle, and this is a transcaruncular approach combined with the transconjunctival approaches. All these procedures collaborate with our oculoplastic surgeons, Professor Wu, and then after incision of the conjunctival, we can easily identify the medial laminar papillary. You can see here. Then we directly open the orbital area. Here. Then we open the cystic mass. We remove the tumors as much as possible. And after operations, all tumors were removed. But this patient has some the limitations of the extraocular movement. I need to take time to completely recover. I hope so. And this boy complained of lateral gaze limitations, even immediately after trauma. And then we found that from his MR imagings, we found some abnormalities with the greater sphenoidal wing. And because of the entrainment of lateral rectus muscles, then we performed the transorbital approaches here. It's the same surgical technique we applied. Then you can find some abnormal finding of the periorbital. Some part of the lateral latissimus muscle was entrapped into the fractured line of the greater sphenoidal vein here. Then we reposition the lateral latissimus muscles into the orbital areas. Thus, after operations, the limitation of the lateral gaze was recovered. And other, because of my time limitations, I will skip other challenging indications. And I have some experience of petrous apex lesions. And petrous apex lesions, according to the location of the tumors, we can access with the endonasally, well, we can access the transorbitally, and then I'll skip it. As I already published this video, then I'll skip. And I'm now trying to remove the temporal parenchymal tumor or glioma with transorbital approaches to preserve the visual pathway. This patient had a repeated epilepsy seizures. The tumor was DNT, and the tumor was located the medial side of the tumor. We performed the transorbital approaches. Same surgical techniques. Then we opened the temporal dura, and you can find the temporal parenchymal tumors under the guidance of the neuronavigations. We identified the temporal horn. Then you can find the choroidal plexus. Then we identified the amygdala and hippocampus. I removed the amygdalo-hippocampal areas, and with using the frozen biopsies, this area was involved by the tumor areas. Then we removed the medial part of temporal lobe, not injuring the lateral cortex or not injuring the visual pathway of optic radiations. Then we close it. After operations here, so we are going to follow up with the visual field and acuity. And this is maybe another case. Yeah, this is maybe cavernous malformation after radiations. And then we perform the cavernous malformations, transorbital approaches, the same technique. Then we expose the greater sphenoidal vein and temporal dura. You can find the Cerebellar vein is here. We target to the more inferior part. Then we reach the cavernous malformation part within the temporal side. Then we perform the gross total resection of the tumor. Then we put the fat graft. Yeah, I skip. This is another case of the recurrent meningioma cases. I skip, but I need to show my video. After operations, you can find the dilated temporal horn. Then we can, if we enter this temporal horn side, you can find the amygdalo-hippocampal complex. So I thought that this is a good target for the transorbital approaches. And so I thought that after operations, and then this is another case of the recurrent meningioma, recurrent trigeminal schwannoma involving the infratemporal fossa areas. I skipped that. This is, I'm now trying to anticlinidectomy with the transorbitally, but I'll skip it. I'll skip. And this is not of the face. I skip. I'm sorry. Anyways, anticlinidectomy is possible with the transorbitally or supraorbitally and so on. Each only the showing cases, demonstration cases. I don't recommend. Everyone don't have to do it with the transorbitally. And so, and then anyway, after the anticlinidectomy, I removed the tumors, and effectively we remove the tumor here. And this now, and then transorbital approaches can be combined with endonasal approaches. And then I have experience of 9 cases of combined approach with endonasal and transorbital approaches. And sometimes these fractured cases, we endonasally, we remove the fractured bony fragment and also remove the optic canals transorbitally lateral part of the greater sphenoid wing. Then sometimes we combine the oculomotor schwannoma, and then this tumor is another case. I'll skip. And I'll skip. Yes. And transorbitally or endonasally, but it takes very long time. It took very long time. So I'm just only to enter the infratemporal fossa areas, and I favor the endonasal approaches, and cavernous portions, I favor the transorbital approaches. Let's talk about complication of these approaches. And temporary ptosis is a very common side effect of these approaches, but most common ptosis was fully recovered, only eyeball swelling, eyelid swelling. So we don't have to worry about that. So there was no cases of injury of levator muscles. I have 2 or 3 cases of CSF leaks. All cases were relieved with the lumbar drainage, not requiring the second revision surgery. I have 1 case of enophthalmos after operations of endonasal and transorbital approaches, but except then, I have no cases of enophthalmosis. And then sometimes we need to accumulate our experience to avoid the wound problems. And cosmetically, I'm very satisfying, and my patients are very satisfied with the cosmetic issues. In conclusions, I think the selection of indication is very, very important for the transorbital approaches. First one is pre-orbital meningioma and middle cranial fossa, such as trigeminal schwannoma. And orbital tumors can be collaborated with the oculoplastic surgeons. And also middle cranial fossa tumors were sometimes extending to the infratemporal or posterior fossa, or extending to the cavernous sinus, must be a very good indication of these combined approaches. And above all, and thorough knowledge of the anatomy and cadaver dissections can overcome this learning curve. Thank you. Thank you very much.
Thank you, Professor Du Gong. I think it was very, very impressive lecture. So is there any doctor have the question to him?
Yeah, can I ask one question, Professor Goto?
Okay.
What
Professor Neya, please.
What a great lecture, and really amazed to know that you can reach virtually every part of middle fossa, orbit, or even up to posterior fossa through orbit. My one question to you, and you told that a beginner should start with trigeminal schwannoma. So between 3 approaches, transpterygoid, transorbital, and the middle fossa approach, do you choose your approach based on pre-operative where the trigeminal fibers are displaced? Because, you know, even though I have no experience, I have only experience with middle fossa approach. Once I listened to Professor Gardner from Pittsburgh telling that if the trigeminal fibers are displaced lateral to the tumor, it is best to go transpterygoid. How about your thing? Is your approach has any relevance to disposition of trigeminal fibers by DTA before surgery? Please, Professor.
Yes, I will agree with your opinions. And transpterygoid and quadrangular space, and then we can fully remove the tumors. So I tried several times. So I totally agree with the Gardner's idea or Pittsburgh group's ideas. But we have to know, we need to remove many normal structures within the nasal cavity area. Frankly, we have to be more honest. I know, we are all neurosurgeons. Nasal cavity structure is not important for me anyway, but we need to destroy some structures, destroy the median nerve, and also it's a very long pathway to reach the cavernous portions or temporal portions. And then compared to the endonasal approaches, I agree the endonasal approach, if you are very the master of the endonasal approaches, and then you can do it. But if you are not the master of the endonasal surgeon, and then instead of that, I recommend the Transorbital approach. It's a very short distance from this area, and then of course, very small space, I know, but the more direct approaches, and you can easily identify the internal carotid arteries compared to I'm very familiar with the transorbital approaches, but some beginners are very unfamiliar with these approaches. So we need to balance which approach is much better for me. So we need to balance the endonasal or transorbital or retrosigmoid or anteropetroidal approaches is still good options, I think.
But what about control of carotid artery? Is it better through transpterygoid? You reach foramen lacerum, you know where the carotid artery is, and then you have control over that, and then work on the tumor. As opposed to your approach, when do you get control over carotid artery? For large lesions. Large lesions of middle fossa going to posterior fossa. Your control over carotid artery, I think, is better through a pterygoid approach. No, I don't know. I am asking you. Or Professor Goto can tell.
I prefer to use endoscopic subtemporal approach. So another approach, I insert the endoscope to subfrontal space and directly cut the lateral wall of the cavernous sinus and go into the tumor capsule and reject the subcapsular dissection. It's another option. Anatomy is easy, but I think the transorbital approach has a good access to the tumor. So I think one of the ideal approach to the trigeminal schwannoma if we learn the anatomy. So Professor Kong, I have the one question. I want to introduce the transorbital approach in our institute. Is it better to collaborate with a plastic surgeon to cut the skin eyelid incision? How about this problem? You perform by neurosurgeon alone or collaborate with a plastic surgeon?
Of course, I collaborate with our oculoplastic surgeons from the ophthalmologist, and she's a very skillful ophthalmologist, and we collaborate with her still, and to achieving the transcaruncular approach. We don't know how to inside the conjunctiva, but because nowadays she's very busier than the neurosurgeon. So it's very important. It's very difficult to make a time with her, and then the transorbital orbital phase is very simple and only takes 10 minutes or 20 minutes. Only incision of the skin and by the orbicularis muscle, then we expose the lateral orbital wall, then it's enough. And then we change to the neurosurgeons. And nowadays, my neurosurgical fellows can do it. And then drill the greatest sphenoid wing. It's almost like the terional approaches. When you remove the terional approaches, and you don't have to call the plastic surgery, and then
Which part should I cut? Which part should I cut? Along the eyelid, along the wing, or?
If possible, I follow the eyelid, double eyelid, but those part, Northern Asian part has no single eyelid. And then there is some the scar. For me, I'm the single eyelid, and then maybe. But most patients has a double eyelid, and then I along the superior eyelid crease, then there is no scar.
Okay.
Thank you very much, Professor Dusik Kong. It was indeed a very wonderful lecture, and you have wonderfully demonstrated this approach to resect various lesions of the brain. One question I would like to ask to you is that in our institute, we do a lot of orbitozygomatic approaches for basilar apex aneurysms and all. And when we do that, when we retract the globe, we have come across one or two instances of oculocardiac reflex or the ACNS reflex, which is drop in heart rate due to the pressure on the globe. So our anesthetists say there is sudden bradycardia. How much of this have you encountered in transorbital approaches in your experience?
I have many experience of the oculocardiac reflex during the transorbital approaches. And sometimes we retract the orbit area, and then bradycardia occurs, and my anesthesiologist call me and stop. And then I recommend that just the retraction time is within the 10 minutes. And then we can, when you peel off the trigeminal lobe from the temporal lobe, and sometimes the bradycardia occurs, and then we just stop. It's very common things. So I complain of these problems with my ophthalmologist, oculoplastic surgeons, and she responded, "It's a very common side effect. So don't worry, just only take a breath, take a rest, and then within only 10 or 15 seconds, the heart rhythms recovered. There was no problems."
Thank you very much. Any questions?
Thank you, Professor Kong.
Yes, Professor
Very
is here.
impressive lecture. I have another question, maybe last one. So this is a transorbital approach. So is there any complication for the pressure change of the eyeballs, like post-operative glaucoma, this kind of thing?
Yeah, that's good questions. I also worried about that after opening the greater sphenoid veins, and then brain may contact with the orbital, and then we worrying that pulse pressure, but actually the size of the cranial, size of the opening, bony opening is very small. Actually, there was no contact point from the brain and orbital structures. It's very small. With the endoscope, and we can widen the view, but actually the size of the opening is very small. So, and then also, greater sphenoid wing is very thick, and it takes maybe 30 minutes or over 30 minutes to drill the greater sphenoid wing, and other remaining part of the bone is very still thick, and there is no chance of the contacting between the brain and orbital space. This is not orbital loop. Lateral part is very thick, so you don't have to worry about that.
Thank you.
Thank you very much. We'll take one last question from my co-host Liu Bun Seng.
Thanks, Raja. Thanks, Professor Kong, for a very nice presentation. I just one question regarding cavernous meningioma. Do you think that the transorbital have a higher chance of a cranial nerve preservation compared to transcranial? And in the event of recurrent, can you use back the same approaches? Thank you, Professor.
I'm sorry, I don't get it. As you mean for the cavernous
meningioma, cranial nerve preservation compared to transcranial. And in the case of recurrences, can you use back the same approaches?
Yeah, so for cavernous meningioma, is the principle of the treatment is almost the same as transcranial approaches. We need to remove the tumors, the maximum safe resections, and then we leave the tumors within the cavernous sinus, and then we perform the radiosurgery or radiation therapy and observe. I think I agree.
So it's just pure cavernous meningioma. You would not perform surgery, Professor?
I know.
Pure cavernous, no. Okay, thank you.
Yes. Yeah.
Okay, right. Thank you very much, everybody. It was indeed a very wonderful presentation, and we learned a lot. Thank you, Professor Dusik Kong and Professor Taki Goto, for the first session. Then we can move on to our second chair, Professor Shubin, who will then say a short introduction and invite Professor Dr. Azman Rafiq. Professor Shubin, all yours.
Okay, thank you, Professor Goto and Professor Kong again. So now let's give the time to the second speaker, Professor Muhammad Azman Rafiq. His topic is AVM experience in surgical plan, techniques and the complications avoidance, lessons learned.
Thank you, Prof. Zubin.
Okay.
Thank you. Thank you, Dr. Kuti, and thank you, Dr. Raja, and thank you, Mr. Liu, for this gracious invitation. My name is Azman Rafiq. I'm from Eurosuri Penang, and I'll be talking about AVM surgery, particularly focusing on some of my experiences and the lessons that I've learned when dealing with AVM surgery. So AVMs are, for me personally, and I think for many others also, complex and technically very challenging lesions. No two AVMs are actually the same in terms of anatomy. The anatomy of every AVM is quite variable in terms of its location, angioarchitecture. You have compact niduses, you've got diffuse niduses. And one of the big challenges when it comes to AVM is there's no predefined pathway of surgical approach and manipulation. You can't take one AVM example and apply it to the next. Every AVM is unique in its own way. And hemorrhage in AVMs can be quite torrential and rather difficult to control as well. But good things about AVM is that it is essentially, when compared to aneurysms, they are low pressure systems. And the intervening or surrounding brain tissue is usually gliotic, non-functional, and they serve to define the plane of surgical manipulation. Most AVMs are visible on cortical surface, so when you open it, you see it, and you can easily plan approach and access. Brain swelling is usually less challenging, apart from those AVMs which are approached acutely. Most AVMs are approached in a subacute phase, and you don't really have to deal with so much of brain swelling. One good thing about AVM is that you always find a compass, and the venous compass is good in helping the surgeon guide surgical planning and progress. So these are the few lessons that I learned when dealing with AVM lesions. So essentially, planning is very, very important when it comes to embarking on any form of AVM surgery, and that involves meticulous review of all DSA images and MRI to properly understand the anatomy of each AVM. Most importantly, when we look at it at the angio, the shape of the AVM, the type of nidus, the presence and location of any blood clots, the relationship of the surrounding brain, whether you're dealing in an eloquent area or a non-eloquent area, and any visible structures on the superficial cortex is essential or important to us, to me, when I'm doing AVM surgery, because it guides me to a starting point. So this is an example of a parietal AVM, large nidus. And looking at this, one can surmise that the draining vein forms the most important compass to guide me into the AVM, as well as to guide me towards the progress of the surgery. So looking into this images, again, the MRI. So on this MRI, what is important is the location of the blood clot, and in the event that we need more space or we need a good working space, the blood clot becomes a useful ally to us in approaching and accessing these AVMs safely and effectively. Another example of a cerebellar AVM, again, the anatomy is important when actually defining our surgical plan and surgical approach and manipulation of this AVM during surgery. This is another image. This is obtained via brain lab ICG, and you can see actually the feeding artery, the nidus, and the draining vein. And all these images are important to anyone who's trying to attempt an AVM surgery safely and effectively. Oh, sorry. Yeah. So this is the concept of a box concept, which was developed by Prof. Lawton. I find it to be exceptionally useful in my practice. I've learned a lot from it. It technically defines an AVM surgical anatomy based on individual angioarchitecture. And AVM is a lesion with no defined border. So the box, the Lawton box, that's how I would call it, creates a borders to a lesion without borders. And what is important is the angiographic anatomy. It delineates the structures relative to the surgical field. So this requires good study of the DSA and MRI, and using this information, create a border around the lesion and map the location of each of these important structures during surgery, particularly with particular emphasis on the arterial feeders. The veins always form the best landmarks, and the AVM box, as was created by Professor Lawton, actually is an important guide to a systematic approach to an AVM, and helps us guide our way towards as we are progressing during AVM surgery, because sometimes when you're dealing with large, compact, and diffuse nidus, it's easy to get lost. So what is important is to define a starting point and end point. And I found the AVM box as defined by Professor Lawton very, very useful in my approaches to AVM. This is an example of Professor Lawton's box, easily available in his textbook. And this is an example of how I have applied it in some of my cases, posterior fossa AVM. So essentially define where will be the starting point, where will be the draining vein, which forms a critical endpoint, where we operate last, where do we start, how do we progress, which circumferential movement would one like to take, whether working in a clockwise manner, anti-clockwise manner. So this box really helps guide a person during AVM surgery, because it's easy to get lost when performing AVM surgery. So ABC is something which it has helped me a lot. ABC is just how I would call it. It's essentially a plan of action. It's a stepwise approach to safely excising an AVM. And it starts from planning the perfect patient positioning to gain the best access, to identify where will be the starting point, and to subsequently help us in a stepwise progression towards excising the AVM safely and effectively. We have to aim to anticipate and avoid intraoperative or postoperative complications that can occur. And the main idea is to always have control on the AVM throughout surgery. I think AVM surgery sometimes can be quite a daunting task to many surgeons, including myself. And one of the main problems as you progress throughout an AVM surgery is you tend to lose control over the AVM. And I think it's very important, if available, to use as many adjuncts as it's available, ICG, Doppler ultrasound, or even IGS. And on patients, preoperative adjuncts, if required, is definitely useful. For example, preoperative embolization to downstage an AVM to make surgery safer, faster, and definitely less bloody for us. So I define A as approach and access. What is important that I've learned from my practice is actually having good, adequate exposure of AVM itself and the surrounding eloquent area. As for superficial AVMs go, I think it's best to expose the entire margins of the AVM. When dealing with a deep-seated or probably diffuse Nidus AVM, the exposure should include the entire overlying brain tissue around the AVM. The axis of approach is important to be defined before even starting an AVM. One can either choose a parallel or a perpendicular axis to an AVM, depending on suitability or what we're comfortable with. I have always chosen a parallel axis. It gives me the best view and control over an AVM. The MRI images, as I mentioned earlier, helps us guide or select a window of approach. And in most cases, sometimes a glytic plane or a CSF trap windows form the best windows of approach into getting to AVM. And what is most important is to actually identify a starting point. And this is easily done based on the landmarks available on MRI or angiogram. The starting point is very important because it gets us entry into the AVM at the start of the surgery. So as this is an example of exposure, basically it's important to expose the whole AVM to see everything around it, draining vein, the surrounding brain, the glytic plane, and choosing axis of approach. I've always tried to maintain a parallel approach, so I will position the patient as best as I possibly can to get a parallel approach into the AVM. But in terms of dealing with AVMs in the posterior fossa, I think sometimes perpendicular approach tend to be the best approach into getting into the AVMs when dealing with AVMs in the posterior fossa. It's important to always, if possible, try to correlate the anatomy that we see on the angio with the anatomy that we see intraoperatively. So this gives us a sense of confidence that we're on the right track and helps define our surgical progression during surgery. So this is one of the very important lessons that I've learned as well. I think once you get to see the anatomy on table as you see in the angio, you're on the right track. So as I said, it's always important to first, the A part is to identify a starting point. So in this case, we can use the glytic subchondrite plane as a starting point. In another case, identifying the feeding artery and using that as a starting point. So I think getting a right starting point certainly is a good start to surgery. AB, so B refers to the eloquence, the brain eloquence, referring mainly to the brain around the AVM. So when dealing with an eloquent area, it is very clear it's very important for us to maintain a clear demarcation of what is eloquent and what is non-functional cortices, making use of non-functional cortices as much as possible during surgery. it is important to always delineate margins of dissection around the AVM. And what I've learned from my practice is it is always safe to remain circumferential, hugging the AVM. And from the MRI images that are made available before surgery, identifying available glyphic planes and using them to our advantage during surgery has proven very useful. And as best as possible, I think this should always be taken into account. And if a hematoma is present, it's definitely a bonus because we can use the hematoma cavity as a good plane or window of approach in getting to the AVM, as well as helping us achieve good brain relaxation during surgery. So when dissecting, I find that it's safer to always remain within the border of normal and glyphic brain. When dealing with compact nidus, it's best to always stay very, very close to the nidus, hug the nidus as one would speak, because in compact nidus, we usually find very distinct margins, almost none or no intervening brain structures, and the nidus easily separates from the brain. So when dealing with compact niduses, the best idea is to stay as close to the nidus. But in diffuse niduses, it's not that easy. We may require wide dissection. Well, of course, essentially, the best option is to stay within the border of what is gliotic brain and normal brain. There are no clear margins in diffuse nidus, and most often the AVMs are surrounded by a mixture of both gliotic brain and normal brain. It doesn't easily separate from the brain parenchyma. And what happens is there's a big risk of creating compartments within the working zone. So you may end up inadvertently leaving some AVM behind without even realizing it. So this is an example before surgery, being very clear on what nidus we're dealing with, a compact nidus versus a diffuse nidus. In a compact nidus, the aim is to get to the nidus and hug the nidus. But when dealing with a diffuse nidus, then it becomes a little less clear, and we may need to go around in a larger wide arc and try to get the whole nidus out. So in terms of dissecting planes, I think three very important planes of dissection is present, and each needs to be treated with respect. The subparietal dissection is the first beginning point of the dissection, and this is where we identify the actual starting point of the surgery. The aim is to expose the entire margins of AVM in a superficial and circumferential manner. The next plane of dissection that we encounter is the parietal dissection area. And this is actually where the beginning of the AVM surgery actually occurs. We start by devascularizing the AVM, and again, always remaining circumferentially, create a working plane when we begin our parietal dissection. The final part of the dissection involves a parenchymal dissection, and this is essentially devascularizing and decorticating the entire AVM from the surrounding brain structure. And one of the important factors when it comes to parenchymal dissection is to actually be very cognizant of the presence of deep nidus and the feeder vessels, because they tend to just hide within normal brain and slip away from us, and that will one of the most common causes of post-operative hemorrhage. So in terms of dissection, again, as in terms of subparietal dissection, the idea is to always stay close to the nidus if you're dealing with a compact nidus, and create a good subarachnoid plane, delineate the AVM circumferentially, start off with needle dissection, whatever that is convenient or suitable, and expose the entire margins of the AVM, keeping a very clear demarcation between AVM and eloquent brain regions. As we move deeper, we start going into parietal dissection, and at the stage of the parietal dissection, what is important is to identify the main feeders and disconnect them. So the actual beginning of AVM surgery begins in the parietal dissection, and this is where it is essential to be very meticulous in terms of disconnecting the feeders into the AVM, and by doing so, it'll create a plane as we go on and in our quest to remove the AVM safely and effectively. And finally, when it comes to parenchymal dissection, this is where the border between normal brain and glyphic tissue at times becomes not very clear. And this is an area where niduses can be hidden from view and we can lose track of the niduses. So it's important to always try and follow the vessels in, try to look for the niduses, and as much as possible, remain between normal and glyphic and disconnect all the vessels that are feeding into the AVM. So this is an example of staying within the border of normal and nidus. So identifying a deep nidus is very crucial. Deep niduses, as what is described, located very deeply within the brain, and sometimes it's hidden by overlying brain. And more often than not, there are small feeder vessels feeding directly into the deep nidus, and these vessels need to be treated very effectively and properly, otherwise it will lead to postoperative hemorrhage. C, as how I've described it, stands for collateral vessels. I think what is important about vessels is to identify the different type of vessels that are related to the AVM. You have the terminal arteries which feed directly into the AVM, and most important, you've got the transit arteries which passes through the AVM. They send feeder branches to the AVM, but they actually progress on and supply normal parts of the brain. And you've got the bystander arteries. So these three arteries technically come into play quite often when we deal with AVM surgery. So it's important to identify and cauterize each vessels meticulously. I think what is important is to, if in doubt, it's best to always follow the vessels to the AVM. Most importantly, to be very careful with with the transient arteries, as they give off feeders but proceed and progress to normal parts of the brain. So inadvertent cauterization of this does lead to quite a bit of complications post-op. This concept of dirty cauterization, I think this is an important concept because AVM vessels, they do not die off, or they're not that easy to coagulate, and they tend to reopen. So I find that catching a bit of normal brain or glytic brain with the vessel really helps in securing hemostasis when dealing with AVM vessels. So this is an example of arteries which are just transit. This is a bystander artery at the base of the lesion, and this is a transit artery giving off branches which was ligated. Another transit artery giving off branches, and it continues on. This is an example of a feeding artery, bystander artery. The AVM nidus lies here, and the artery are they're just flowing over it. And it's important to identify these vessels and separate them, otherwise they'll end up with infarct post-op. So it's very important to pay a lot of attention when dealing with the deeper components of AVM, and I find it safest to always follow the vessels into the AVM if in doubt. D stands for draining veins, and draining veins actually serve as a guide or a compass of surgery. They indicate the progress of the surgery. Looking at the size, color, and consistency change of the draining vein throughout surgery tells us that we're on the right track or not. Most draining veins are visible on cortical surface. They form the analytical landmark. And when it comes to draining vein, I think it's consistent to remember that there are three principal types of draining vein. We usually see a primary draining vein, which is left till the end, and this is easiest identified on the DSA. And as rule dictates, never touch the draining vein until the end of the surgery. Occasionally, there are many secondary and deep draining veins, and these draining veins it requires good anatomical understanding of the DSA to identify it early and to remove them as we are progressing during surgery, because they tend to hamper our progress from time to time. They obscure the surgical field. So it's always important to identify the primary draining vein from the secondary draining vein. So looking at the DSA anatomy, so in this case, example, the primary draining vein overlies the entire AVM. So this forms a compass for us, or for me, to guide me through surgery. And as surgery progresses, this is another example of draining vein. So this will be the primary draining vein, the secondary draining veins all there. So it's essential to identify which one is the primary draining vein. That is the only vessel that needs to be preserved till the end of surgery. The secondary and the deep draining veins can be taken out during surgery. So when performing AVM surgery, I think good understanding of the venous anatomy is essential so that surgery progresses in a safe and effective manner. So this is an example of surgery. As surgery progresses, the draining vein changes in color, and towards the end of surgery, there is a change in color and consistency, and it's safe to ligate once the entire AVM nidus is removed. So I think the draining vein is essentially very, very important. A lot of emphasis needs to be given to care for it. I would say never start any form of dissection from the draining vein. The draining vein should never be the starting point. But bear in mind that sometimes over-reliance of draining vein can also be disadvantageous to us. I will elaborate on that a little further. There are also extracranial factors that needs to be taken into account when dealing with AVM. I think when I first started off, these extracranial factors were not really emphasized as much, but as I progress in my practice, it is very important to make sure that the extracranial factors are well taken care of before surgery even starts. And during surgery, it's best to maintain a constant intraoperative cerebral perfusion pressure and at least maintain it for the next 72 hours if possible. Propranolol as a preoperative medication is optional. Some surgeons practice it. I don't really practice it. I would like to ask the view of the panelists today. When dealing with patients with existing systemic hypertension, therein lies the conundrum, because dropping the MEP throughout surgery remaining constant may actually result in inadvertent infarct. But maintaining it as normal will result in normal perfusion pressure hemorrhage. So this is always a difficult scenario when dealing with patients who have coexisting systemic hypertension. Hyperemic state, it's usually what we use and do for patients with aneurysms, but in AVM surgery, I think hyperemic state has to, or is best avoided at all costs. Remember, I find that AVM surgeries can be very challenging mentally and physically. And in some parts of the surgery, I think towards the closure, it might end up with complications, simple, avoidable complications, subdural and extradural. This should be avoided also. These are very important extracranial factors. When planning to extubate patient, I think it's very important to ensure that anesthetist has or ensures smooth extubation at the end of surgery. In some unfortunate cases, there's sudden rise in MEP and patients rebled, unfortunately. So patient selection is very important when it comes to AVM surgery. And I think one of the important factors that needs to be taken into account nowadays is preoperative embolization in indicated cases. I think it's best if we can try and reduce the stage of the AVM, convert the grade 3 to a grade 2, reduce vascularity, reduce operative time, and this will significantly help us achieve good excision of the AVM. In certain cases, I think when there is presence of high-risk nidus or intranidal aneurysm, if it is available and feasible, selective embolization does really help in aiding good surgical dissection. Like I said, I think AVM surgery for me personally can be very fatigued in long hours at times, and ensuring a good ergonomical surgical position is essential during surgery. And it's most important to never start an AVM surgery before ensuring that all images, all equipment that is required are there, and if possible, working in teams. But I think it's not usually possible to work in teams when it comes to AVM surgery. Another team can't take over, but I think there are some centers which practice that. So these are important factors that also come into play during AVM surgery that I've learned from my time in practice in performing AVM surgeries. So this is a case that I would like to share and show. I mean, it's a lesson, very important lesson that I learned during my practice. It's a case of a 30-year-old lady with underlying hypertension, came in with sudden onset of severe headache, slurring of speech, right-sided hemiparesis. She was drowsy on admission. Her GCS was E3, V3, M6, pupils were active on. And on the scan, what we see is a large flame-shaped hemorrhage over the left parietal region. An angiogram was done, and this was the preoperative angiogram. It was a left parietal AVM, nidus about almost about 3 centimeters, predominant superficial draining vein. And surgery was done. Upon opening, AVM was visualized, draining vein was visible. There was good dissection planes along the AVM. Dissection proceeded in a stepwise progressive manner. No immediate complications during surgery. The draining vein collapsed, we ligated it. And this was the post-op scan. Within 48 hours, she rebled. And I did an immediate urgent angio, and what is clearly visible here is residual nidus. So this is definitely a lesson to learn in practice, because when first starting off, what is visible here is what appears to be nothing more than a compact nidus. But outside this area, I overlooked the entire diffuse, very little, not much, but diffuse nidus. And that was the main cause of my downfall. I left back the diffuse nidus. And of course, went in, excised the entire AVM again, and she made a decent recovery, but there was still residual hemiparesis post-op. So the lessons that I learned, which I wanted to share, is this is when I realized that there's a concept of working in compartments when we're doing or when I'm operating on AVM cases which have both compact and diffuse nidus. There is a tendency to just focus on the compact part and overlook the diffuse part. It could be fear of encroaching into an eloquent area, but leaving that behind resulted in bad complication. And I think this is very important, that to really have a clear idea of the nidus, it can easily be dissuaded during surgery. Once we find a compact nidus, the tendency is to stick to the nidus, but the AVM images on angiogram tells us the real story that's happening there. In this case also, what was the other cause of hemorrhage was there was a small arterial feeder lying under the main draining vein. Again, it was overlooked because once the draining vein collapses, it is normal instinct of surgeon to quickly put a clip, be happy, and start closing. But sometimes I made the mistake. I did not identify the arterial feeder, but they are present from time, and it's best to identify and ligate them separately from the draining vein. This is also an important lesson to learn because of the reliability on anatomical markers. We are taught from textbooks, from surgeries, look at the draining vein. When the draining vein collapses, becomes less tense, then you know you're progressing well. Once you get the whole AVM out, you will see a change in color of the draining vein. The draining vein collapses, you put a clip and you're done. But I think it's important to have clear idea that sometimes over reliability on analytical markers may prove as a downfall also during surgery. This is another example, one of the unfortunate complications. AVM surgery is fatiguing, long hours at times, and towards the end, we tend to make mistakes. So I think it's very important for all of us to understand and to remember that we need to remain meticulous from exposure to closure. So in summary, when it comes to AVM surgery, the lessons that I've learned from my practice is number one, and most importantly, is always good patient selection. Select the right patient, the right lesion, and meticulous planning is the key to a progressive, successful surgery. Each case requires individual meticulous planning. No two AVMs are the same. This is also a lesson I learned in practice. Understanding the angiographic anatomy and the MRI anatomy in a very clear manner and translating it to the surgical field is still something which is essential. It requires practice, and the Lawton box concept has really helped me a lot in terms of approaching this AVM surgery. Essentially, it has created a defined workspace to an undefined lesion. And most importantly, what I've realized is you must have a clear plan of what to do before surgery starts, including what to do when things go wrong. And as much as possible, if adjuncts are available, ICG, ultrasound Doppler, I think if these tools are available, it is at this moment essential tools for safe and effective surgery. So this is just me sharing a little bit of what I've learned from AVM surgery. I would like to thank the organizing committee for graciously inviting me to share some of my experience. And Merry Christmas to everyone. Thank you.
Thank you very much. It was indeed a very nice presentation and very valuable to young neurosurgeons. Professor Shubin.
Thank you. Thank you, Professor Azman, Rafiq. Very nice presentation. And do you combine some pre-operative improvisation for surgery? Mm-hmm.
Yes, Prof. I think recently I've started to do that, especially with the advent of Aruba patients that come in with complex AVMs or AVMs with grade 3, grade 2 bordering to grade 3. I find that downstaging the AVM, downgrading the AVM from grade 2 to from grade 3 to grade 2 or grade 2 to grade 1 really helps in surgery. I think most importantly, it reduces the amount of bleeding during surgery. It really helps in terms of surgical time. And I think the embolic material also helps define the space. So in selected cases, yes, I do combine embolization with surgery, especially for the slightly deeper seated AVMs in my current practice now, most definitely.
Okay, thank you.
Thank you.
Thank you very much. I believe Professor Shubin is not in favor of embolization in his practice.
Yeah, yeah.
Yes, I'm both doing the embolization and the open surgery. Yeah,
Oh.
yeah.
Right. Thank you very much. Any questions?
Sometimes it's a very difficult to directly resect the AVM Nidus.
Okay.
Do you have some experience for the so-called normal pressure
Perfusion breakthrough?
Yes.
I've had the unfortunate experience in that. I think two of my patients, unfortunately, both young patients below the age of 30, came in with an acute clot. So I went in rather early. I think I went in within a week. Within a week, took out the entire AVM. Patients were well, but at day 5, they started developing edema, infarct, brain swelling, and I lost one of the patients. The other patient remained hemiparesis. But both AVMs were cortical, subcortical, probably about 2 centimeters at most from beneath the cortex. Supratemporal AVMs. We tried to keep the blood pressure normal throughout surgery. I did not start on propranolol, but ever since those 2 episodes, I have made it a regular point to start on propranolol post pre-op. I do not know whether that entirely helps. Journals say it does, but I cannot entirely explain why NPPH happened for both patients. One of the factors that I put into play or put as a cause factor was hyperemia. I think I should have been a little bit more careful about the amount of fluids that we get for the patients. So this was my experience, 2 unfortunate cases.
Okay.
Thank you very much. Any questions from my co-host, Dubun Singh?
Thanks, Raja. Thanks, Tasman, for a very nice presentation. Just want to ask from your experience in preserving the last draining vein, do you find there's any differences for you for the superficial draining vein and the deep draining vein? Thank you.
Yeah, I think deeper draining veins, if the deeper draining veins are the principal draining veins, you tend to encounter it during surgery, and sometimes you tend to injure it inadvertently. They tend to lie underneath the nidus. They are far away. They're actually, in terms of surgery, they're further away from you. So the superficial draining veins are always easier to encounter, and they serve as a good landmark to tell me that the AVM surgery is progressing well. Deeper draining vein you see towards the end of the surgery. So sometimes we see it only towards the end after all the nidus is removed. But I have also inadvertently injured the deeper draining vein while trying to go around the nidus. So of course, if given the choice, I would definitely be much happier to deal with any AVM with the superficial draining vein.
Thank you.
Right. Thank you. Thank you very much. One of the newer methods of resection includes that you tag each feeding arteries on the neuronavigation, and you directly go to the bottom and catch the biggest feeder, and you come up from the bottom rather than going in a conical manner as described by Professor Lawton. This is also a very good technique. And this was being presented by our previous speaker, Professor Neerav Patel from Boston. And as you said, the dirty coagulation is indeed a very important thing in AVM surgery, which was recommended by Professor Juha Harnes-Niemi. Wonderful technique also.
I do have one question though.
Yes,
propranolol, what are the views? Because I don't know, I don't really practice it so much. But propranolol as an option, is an old option, it's an old adage. Are we for it? Is it useful? I can't really say. So I was hoping to get some views.
Of course, answer that, Professor Shubin.
Excuse me, can you speak again?
Pre-operative use of propranolol.
Propranolol, yeah.
To prevent normal
perfusion
pressure breakthrough.
Do you use it, Prof. Zubin, in your practice?
No.
No, Professor
No.
Shubin doesn't use it. Right, Professor Shubin, you may say the concluding remarks.
Okay, thank you, Professor Rafiq and Professor Kong. Today's webinar is very successful, and in the WeChat channel we have 1,400 audience watch your presentation. Thank you again.
Well, that is a huge number, and we are
Mhm.
sincerely indebted to Professor Shubin for broadcasting these webinars on the WeChat channel. So that we can wind it up now, on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaita, I would like to sincerely thank both the speakers and chairs for today, Professor Azman Rafiq, Professor Dusik Kong, Professor Takya Gota, and Professor Shubin, and all the distinguished dignitaries, Professor Suresh Nair, and others who have joined us in the webinar. A special thanks to my co-host, Dr. Liubun Singh, and Professor Shubin also for broadcasting this on the WeChat channel. So until we all meet on 25th of December, it is bye-bye from all of us. Thank you very much. Thank you everybody for joining.